first organization of its kind in Canada. We have been around now for 28 years. I need to change that. And for the past 4 years, we have been serving all of British Columbia. So we are a provincial organization, and we try to reach everybody in BC. All of the staff have caregiving experience, and 60% of our board members must also have caregiving experience. We do a number of different things, and I would encourage you to go to our website, and you can see the address for our website down at the bottom of the slide because it will give you more detail about all of these. But we have a 1-800 line across BC, and you can phone during business hours and receive emotional support, navigation help. We'll refer you to resources, both provincial and in your community. And Wendy, who's on the screen there, does consults for people who are experiencing really challenging situations. Then we have our education component, which consists of our webinars, like what we're doing tonight. We do workshops and presentations and some training in person. And our third area of focus is collaboration and engagement, and this is really a passion for us as we are trying to make sure that family caregivers are represented in our healthcare system. So we ask for volunteers who might be interested in that kind of work. If you're interested, we would love to hear from you, and you can reach us by going on our website. You'll see a link there. All right. Just in terms of webinar norms, confidentiality is essential. We'll try and make sure that everybody has a chance to ask a question or if they have a concern, so equal sharing. Everyone has a right to take part, and just be aware that if people are sharing, it may not be your experience, but it's time to reflect and think about what might apply to you or not. Learning objectives for this webinar will be to help you understand what palliative care is, to gain insights into the benefits of palliative care, to learn when and how to access it, and we will have a slide that has all of the information that you will need around references. So I'm just going to point out right now that we do have down at the bottom of the screen, underneath the presentation, there are a couple of documents there that you can download. If you don't do it tonight, they will be included with the recording on our website, so that you don't have to take furious notes or anything. All right, so I'm just going to introduce our panel, and Wendy Johnstone is our coach caregiver, and she'll be facilitating the questions and answers. Wendy herself has a master's degree in gerontology and 20 years of experience working with caregivers and seniors. And in addition to her contract work with Family Caregivers of BC, Wendy runs her own company called Keystone Elder Care Solutions in the Comox Valley. Katherine is joining us from Ottawa, and so she stayed up late. Katherine, we love it. Thank you. And Katherine is a writer, life coach, hospice volunteer, and a retired Carleton University professor. She's written several books. Her most recent one is all about caregiving. It's called I Don't Have Time for This, and it's a compassionate guide for caring for your parents and yourself. And I can say I'm about 2/3 of the way through it and thoroughly enjoying it, Katherine. So I would encourage all of you to get a copy. And she works as a hospice volunteer and is also a life coach and really supports people going through the transitions involved in caregiving and end of life. So we're just thrilled to have Katherine with us tonight. Our next panelist and guest is Dr. David May, and David is in Powell River on the Sunshine Coast. You can see him waving there. Just a minute, I'll make you bigger there, David, so everyone can really see you. And he's been a family doc for 25 years focusing in the areas of palliative care and pain management, mental health and anesthesia, and is the board of the Powell River Division of Family Practice. And so he's in a great position to have introduced this project in Powell River, and because he's designed and teaches the palliative care and chronic pain module. And we have also online Christien Kaaij. Am I saying your last name right?
Kaaij, but it's okay.
Kaaij. And Christien is a project manager working with David in Pal River and does all kinds of other things that we discussed when we were checking out the webinar platform. So Christien and David, thank you so much for joining us. And last but not least, we have Pat Porterfield. And for any of you who have joined our webinars before, Pat did a webinar for us on advanced care planning. And what you'll see on the slide is that Pat has over 35 years as a palliative care clinician, educator, researcher. And while she was working for Vancouver Coastal Health, had a lead in helping to extend palliative approach into residential care, primary care, including the participation and development of an end-of-life module for general practitioners. So she and David are going to have lots in common. And Pat continues to educate for advanced care planning and co-chairs the BC Centre for Palliative Care Advanced Care Planning Public Awareness and Education Group. Pat, thanks for coming aboard again. So at this point, I am now going to turn the presentation over to Pat, and Pat's going to cover the first few slides, and then we're just going to run through the presentation.
Okay, thanks a lot for your introduction, and welcome everybody to our webinar. So I want to say, because this slide is pretty dense and pretty historic, that our intent is not to actually go over the history of palliative care with you tonight, but we wanted to illustrate a couple of things by giving you this information about palliative care. One is really how new this concept is. I mean, when you think about it starting in Canada with Belfour Mount in 1973, that's not very long ago, really, to develop a kind of approach to treating people with serious illness and the dying. So it's pretty new. It began in the United Kingdom, and I think many people have heard the name of Cecily Saunders. Even if you hadn't heard of palliative care, you might have heard of her because she began the hospice movement in England and is a fairly well-known lady. So it was called hospice in the UK, but as this slide illustrates in the comments, it was Belfour Mount in Montreal that started to use the term palliative care, and used it because when working in a bilingual setting, they found that the term hospice was kind of associated, especially in French, with places for travelers to go when they were poor and weary and whatnot, and so didn't convey what he felt was really the essence of palliative care, which is, really to try to promote comfort. So that's where the term palliative care came from, and it was about a unit that he established at the Royal Vic Hospital in Montreal, but also his vision of how these palliative care clinicians would go out and work with other professionals throughout the hospital and in home care programs, and also to ensure that people had bereavement support. So palliative care has been evolving since it began in Canada in 1973. And, tonight that's one of the things I think we're wanting to emphasize is that palliative care, although maybe originally was very associated with the care of people when they were imminently dying, that we've really been trying to work on how we can broaden the scope of palliative care. And so I know David's going to be talking about that a little bit too, but that's kind of the theme in these few slides that I'm going to be addressing. Now, do I need to click, or do you move me
I can certainly do it, Pat. Let me just
or I can. I just didn't know. We should have talked about that. Okay. So what is palliative care? So the essence of it is that we're really trying to improve the quality of life of patients and their caregivers when they're facing a life-threatening illness. And so we focus on the prevention and relief of suffering by early assessment and treatment of pain and other problems. But it's not just about symptom management. It's also to really involve the person in the decisions related to their care. And so that's a theme that I'm sure you're going to hear more about tonight as well. The intent with palliative care was neither to speed up nor to delay death. So I know from my own work, when I was a palliative care clinician, I think some people did kind of think that palliative care was about speeding up death, but we were really associated with trying to make sure people had good pain control. Sometimes that involved giving medications that might make them a little sleepy, but if that was the most important thing for them was to have good pain control, we and, as clinicians could accept that that was okay. So I think that the intent always was related to wanting to ensure that people had maximum comfort. I'll move on here. So just as I was saying, it really focuses on care and comfort rather than curing the illness. But again, because we are trying to encourage earlier palliative care, and I'm going to start using the term palliative approach, which is kind of a newer term that we're using to indicate that palliative care can be integrated into chronic care of people with serious illness, and that they don't have to stop their curative treatments. Although those won't be the focus of palliative care, they would still be involved with other clinicians who might be offering them treatments to cure the disease. So it's not that you have to let go of curative treatments, but that you also want to make sure that you're comfortable. And at some point, usually what happens for people when they're living with their illness is that there becomes a point that the treatments that you're involved with for cure become burdensome to you. And it makes sense to you at that point that you want to focus solely on comfort and let go of those curative treatments. Or it may be evident to you and the care team that you have that the treatments just aren't working at all, and so you want to let go. So usually this is a process that evolves over time as you focus on comfort and then weigh how much you want to be involved with curative care. So it consists of medical care. So obviously physicians are very important, as are nurses, but we look also at the social and the emotional and spiritual support. So often on a palliative care team, and it doesn't, when I use that word team, it doesn't mean that everybody has a capital P, capital C by their name. Members of your care team may be your minister or rabbi or whatever religious faith you belong to. They may involve a hospice volunteer who is located in a different organization. So the care team that you put together, you want to make sure that they're not just looking at the physical or the medical side of things, that the care team also looks at your social needs and your emotional needs and your spiritual needs. And as I already mentioned, that we're starting to look at palliative care over the illness trajectory to relieve suffering and improving the quality of life. So palliative care can be offered in many settings, and I think because people have been familiar with the concept of palliative care units or hospice, residential hospices, sometimes there's a sense that that's where palliative care is offered, in these specialized settings. But we want to be able to offer palliative care wherever the person is living. So if it's in their home, if it's in residential care, if it's in a different unit in the hospital, we want to be able to bring that philosophy of comfort, of involvement in decision-making, in looking at your quality of life. We want to be able to bring that to wherever you are. So finally, the other thing that we wanted to say, because in Canada we use this term hospice palliative care, and I know sometimes people find that just a little bit confusing. And really, those two terms were combined in Canada, particularly with the Canadian Hospice Palliative Care Association, in order to, again, to convey the idea that both hospice and palliative care are based on these same principles that we've been talking about, but that, programs may have different names. So, you'll have a hospice society in your community that may have or be involved with the residential hospice, as well as having volunteers to support while you're in your home. You may have Victoria Hospice over in Victoria, where they have an inpatient unit, as well as counselors and staff to help people in their home, physicians, nurses helping people in their homes. So you'll hear these terms. Philosophy-wise, they're really interchangeable. So what you need to do when you hear about a hospice program or a palliative care program is find out, well, what are the services that that particular organization offers? Don't make assumptions that hospice is always residential or that palliative care is always in the hospital. We need to recognize that those terms are often used to represent a philosophy of care, and that we need to inquire about the particular service that the organization with that name offers. So I think that's kind of all I want to say about that. And I did mention, I guess, earlier that we are using this term palliative approach now because it got confusing for people, always associating the term palliative care with specialized services. And so the thought was that if we could help people broaden their thinking about where palliative care could be offered. So the palliative approach is really this idea that you can focus on symptom management, you can focus on people being more engaged with their decisions around their care and formulating goals of care, that these things could happen regardless of whether it was a cancer diagnosis or heart disease or ALS or whatever the illness is, and that this could happen earlier than when it was clear that the person was imminently dying. So I think that's probably all I should say. Janet, maybe I should check and see if people have any questions about it.
Great. So thank you very much, Pat. And I think you've almost said everything I wanted to say about palliative care anyway. But I was fortunate enough as a medical student to actually work with Dame Cecily Sanders at St. Christopher's Hospice, and so that was something that stimulated me for a lifelong interest in palliative care. This next slide says, is your loved one palliative? I actually object to the labeling someone as palliative. And what it really should say is, would your loved one benefit from a palliative approach? So why is this important? Why are we wondering whether people do benefit from palliative approaches? Is it just a feel-good approach? And of course, that's a rhetorical question. We now know from pretty hard evidence that people who do receive a palliative approach to their care not only have improved symptom management, which is probably a no-brainer, but actually we now have some studies to show that people live not only better lives but longer lives. And so I think it is important to identify when a palliative approach is appropriate. And you can see down on this slide, we've put some reasons why your loved one might benefit from a palliative approach. The one that isn't down there is just simply personal choice. And fairly often I have patients who come to see me, and Pat's already alluded to this, who really want to de-emphasize the curative approach to life-threatening illnesses, and would like to really emphasize symptom and pain control. So a little step back, Christien and I have been leading in Pal River for the last couple of years a community-based project on palliative care. And one of the aims has been to increase community awareness of palliative care. There's been other aims as well, and we've been educating the doctors and nurses in Pal River. Pal River is a small rural community, about 20,000 people. We have no palliative care beds, and we also don't have any overnight community care. So we do certainly have some challenges. One of the tools that we developed was the All Care Support brochure, and you can see the link to it, the PDF link to it at the bottom of your page there. And this is a little part from it, which talks about a couple of life journeys that are there. And it illustrates a few points. You might need to blow this slide up a little bit to see the details of it. The life journey on the right starts with a serious illness is diagnosed sort of halfway up that stem there. And you can see at that stage that what we've called supportive care, which is really palliative care, but we tried to de-emphasize the word because it came with a lot of stigma, can be appropriate in serious illnesses, even if people aren't going to die. So palliative approach is quite appropriate in all serious, potentially life-threatening illnesses. On the life journey on the left there, you can see that red dot early on the stem. And what we're talking about there is talking about goals of care. The concept of goals of care is something which you'll always hear palliative staff talking about. And it's really talking about how you want to live the rest of your life. And I think goals of care discussions are something which are appropriate at any time, appropriate to have a goals of care discussion at multiple times in your life. And I would say that everybody, including me and my wife, have both had goals of care discussions. And these are going to vary where you are on your life trajectory. So carrying on the journey on the right-hand side of this slide, you'll see that this person has a life-threatening illness, which then progresses into palliative, hospice palliative care. And throughout that time, you'll see different goals of care discussions going on. So this is on our All Care Support brochure, which there's a PDF to it at the bottom of the screen. And I would encourage everybody to have a look at that. So
and can I add a few? Let me go back. Can I add a few things to the slide?
Yes, go ahead.
So what we really try to emphasize in the slide, and that's what Pat talked about as well, is like if you see the yellow boxes, that's active curative treatment. So palliative care is appropriate still if you're undergoing, curative treatment. And in the trajectory on the right side, you see that, maybe if let's say someone has a cancer diagnosis, but then someone for a while is getting better, and that might actually be several years that someone doesn't have any symptoms. But still people will need a bit of care, a bit of support. And when the cancer come back then, and they go into treatment again, maybe eventually then the palliative care gets more like a hospice palliative care approach. Because a lot of people, and you saw that when people filled out the poll in the beginning, 25% of the people that signed on think that palliative care is only appropriate in end of life. And that's the difficulty in Canada with using the term hospice palliative care, that still that association with end of life is attached. Well, research now says, no, it's really very appropriate if you have a life-threatening illness. Then you can benefit already from receiving palliative care. So I just wanted to add that to the slide. Over to you, David.
Yeah, so to reemphasize that and what Pat said as well, that palliative care, it's entirely compatible with curative treatments, and it's a matter of emphasis where somebody is on their trajectory as to which approach is going to be done in priority. So one of the other initiatives we did was to produce some videos for release to various media, and these are available on YouTube as well. And I'm wondering, Janet, if we can show this video. Encouraging people to go and talk to their physician. And the reason for that is obviously to have those goals of care discussions. And there is an added bonus that if you do get to talk to your family doctor and there's an agreement that the person we're talking about does benefit from a palliative approach, they can be registered for the Palliative Care Benefits Program. And it's not necessarily life expectancy of 6 months. There are different criteria that are being used now. And under the Palliative Care Benefits Program, cost of equipment and supplies and drugs are covered. And there's also access to increased funds for home care nursing as well. So we talked about how a palliative care approach can improve someone's quality and sometimes quantity of life. And accessing these palliative care benefits can also help the cost of caring for someone, especially at home. So if you do get, the physician has to fill out a form, yet another form, but the good news is you can tell your family doctor they will get paid for doing that work. So there is a fee for doing that. So the doctor will get paid for it. And so there shouldn't be any reason why the form can't be filled in. And what that will do is to trigger contact with home and community care. And so you should be expected to be contacted by a home and community care liaison, often a nurse, who will do an intake interview with plans on where the care for the future will be and what will take place, and have a goals of care interview with you. And then that should encourage increased liaison between the caregiver, the patient, the physician, and the nursing staff.
Dr. May, can you speak to perhaps some of the differences, for example, when somebody's in hospital? I'll just give you an example of what happened here in the Comox Valley with one of my clients. The family were long distance, and she actually had a representation agreement, and it was on file, et cetera. And she at one point, she had a blockage in her stomach, and they had indicated that there was no cure, there was no treatment, and she didn't want treatment, and so they had considered her palliative. But it didn't seem like it was her family physician. It seemed that it was the acting physician at the hospital. So could you help clarify that, or just speak to that a little bit? I think that was just an interesting question that we also get from caregivers as well as personal experience.
Yeah, it can be a different experience for different people in different communities. Now, we're fortunate in our community in Powell River that we have a family practice-led hospital. In other words, patients are admitted by their family doctor and generally looked after in hospital, with their family doctors being the most responsible physician. In larger communities, family physicians have actually found it more difficult to have admitting privileges, and have therefore don't always have direct care over their patients in hospital.
Right,
and
okay.
So then the problem becomes one of communication. And that's where a caregiver can be vital in advocating for their patient in hospital. Nearly all of the larger hospitals that do not have direct family practice representation do have palliative care teams. And anybody who, and I by the way, I have a little bit of an issue with the word considering a patient's palliative. I much prefer the designation that somebody would benefit from a palliative approach.
Yes, I'm working on it. Thank you.
Saying that someone is palliative sounds something like a death sentence, And although I do get referred to as Dr. Death on occasions, really I consider myself much more a quality of life doctor. And I'm much more about living than I am dying. So
I've just written palliative approach in big letters on my question sheet.
So
Thank you. I appreciate the reminder.
However, getting back to the question, the likelihood is that if your family doctor, with whom I hope you've had a discussion, is not looking after the patient in hospital, then there will be a palliative care team, and I would advocate very strongly for your loved one to have early access to that palliative care team, because then they can help direct their care. Does that answer the question?
I think that's a great clarification for different communities, and I think the piece about a family physician-led hospital versus one that isn't, I think is a real important distinction for family caregivers to understand. So thank you.
So Wendy, there is a comment that someone has just typed in, and I think while we're here, maybe we should answer it, and it's about the different experiences based on different communities. So I think the concern is, does that mean that palliative approach to care varies and is kind of, you never know when you're going to when or what you're going to get?
Do you want to answer that one, Wendy, or shall I?
Oh no, you do.
Thanks. The simple answer is yes. I think the palliative approach does vary across the province.
Yeah.
That there are definitely have and have not communities across the province. And to just have a slight political approach here, if you look at the Health Act, it's all about equality. And the truth is that if you have palliative care in Vancouver, you will have more money spent on you than you will if you have palliative care in Powell River. And to be fair, Vancouver Coastal has recognized this, and they are trying to divert resources towards smaller communities. I think the same experience is also true on Vancouver Island, where Wendy is. And I've done some palliative care sabbaticals in the Victoria Hospice, where the level of palliative care is superb. They have multiple palliative care beds. There is visiting palliative care consultants and palliative care flying squads for people to go to people's homes. That level of care is definitely not available in small communities in British Columbia. To correct some of that, Doctors of BC has organized through an organization called PSP, education modules for all rural doctors. And that's been attended by approximately 50% of all the doctors in BC, all the family doctors in BC now, and on educating family doctors around palliative care. So that compensates for some of the inequalities in palliative care delivery across the province. I think the rest of it is going to need continued pressure on the government, whoever they will be.
Right.
I should mention that was a very pointed comment. I don't know if Katherine picked up on that. We've just had a provincial election, and we're not entirely sure who the provincial government is at the moment.
So could I make a comment? It's Pat. I don't know if you can hear me or not.
Yes, Pat.
Yes,
yeah.
Pat,
Okay. I just wanted to add to what David was saying, because I noticed in that question about the benefits. The benefits is a provincial program. The help with medication costs and equipment, and so that should not vary across the province. I mean, even the most remote communities usually have a physician that could sign you up for the provincial benefits program. Now, the difficulty in terms of getting equipment into some of these communities. I'm sure if we had somebody that worked in home care nursing here, they would tell us about the challenges of doing that. But, definitely the intent is to try to make sure that the benefits program is right across the province of BC.
So we have another question. Does the completion of the request form by the family physician trigger an assessment everywhere as a minimum?
It should.
It should,
right,
yeah.
Right, David? I mean, that's the intent, and that was part of the work that came out of the doing this education across the province, I think, was looking at how we could, ensure that when the physician does the benefits form, that the home and community are aware then that this person is in their community who has advanced illness and is in need of an assessment. And then the family, patient and family and home care can then decide what are the services that would be appropriate for the person.
In our community, it did not happen automatically, that provincial benefits was being done, was not automatically being done at the same time as the local assessment. And part of the project that we did was to link those two processes. So now that when the doctor fills out the provincial benefits, they automatically refer the patient to home and community care. So it actually is a very valid question, because there may well still be some communities where it doesn't, although it should happen automatically, it doesn't always. And that might be something that a caregiver needs to maybe remind a busy family doctor.
Yeah, that's a good point.
Yeah, thanks for that clarification, David.
So I'm just wondering if we should continue with the presentation, and then we'll be able to loop Katherine into the conversation, because she's on the panel, she's kind of our caregiver rep. And so I would like to have her complete the presentation, and then we'll have the full panel open for discussion. So Katherine, why don't you take it away? And those of you online, if you wish to still type in your questions while Katherine is doing her slides, you're welcome to do that.
And you can make Katherine big, I think, on the screen.
Yes, I can, and I will. There we go. Okay, just a minute. Okay, there. Have you unmuted, Katherine? We can't hear you. Did you press star 6 on your phone?
Star 6, Katherine. Maybe she can't hear us, so type it in the box.
Okay, can you hear me now?
Yes, yes.
Yeah.
Okay, good. Good. Okay, I just wanted to add, because I'm the caregiver rep, but I'm also national in that I'm in a different province from BC, and the issues that you're talking about in terms of access to palliative care are issues all across the country, and it's a real problem. The Canadian Hospice Palliative Care Association estimates that somewhere between 18 and 35% of Canadians have access to hospice palliative care. That's an abysmal figure, and many of the people who do have access are in the large cities, as David points out. So if you're in Toronto or Ottawa or Victoria or Vancouver, any of the large cities, Montreal, you're much more likely to have good access to hospice palliative care. But anywhere else, it is, as someone so graphically put it, a crapshoot. It's very difficult. And it's one of the reasons why people are pushing for some kind of national policy and national agenda in Canada from the federal government to ensure that we have some strategy that will provide this kind of care all across the country. And certainly it's what those of us who are involved politically around this issue are pushing for. So, the first point on this slide is caregivers need to be aware of palliative care services, and I guess I'm partly suggesting that in some places there aren't palliative care services, or that they're very thin on the ground, and it's a challenge for people. In my own experience of caregiving, my first experience was in 1997 when I was caring for my sister in Toronto. And really there was very little palliative care that I knew of, and I'm an academic and a researcher, and I tried hard to find anything, and it was very difficult to access. But by the time my father was sick, just a few years later in 2003, there was a palliative care team, as David described it, a flying palliative care team that would go to visit physicians and nurses as well, but the physicians in particular, who would go to people's homes and talk to them and provide what they needed to be cared for, or at least some of what they needed to be cared for at home. So it is true that caregivers need to be aware of all kinds of services that are available to them, and I think the first place to ask is their family physician. And again, that will vary. And some of those physicians, and let's hope that it's going to be more and more of the physicians, family physicians, will have training in palliative care so that they'll be able to provide some of these services themselves and help people to gain access to others. Clearly, when you're caring for someone who has a life-limiting illness, those needs are going to change. And, we often talk about it as a roller coaster. It's certainly not some kind of straight line in any way. And what's frequently happening is you kind of get used to where you are as a caregiver and as the person who is ill. You get used to, okay, this is the new normal, and then it might go for a little while, and then change dramatically with an incident often. And then you have to figure out, again, how to deal with that particular stage that you're in, and try to find the help that you need. The third point on this slide, well-informed caregivers are better able to care for their loved ones. It kind of goes without saying that's the case, but I think that most caregivers are doing their best to be well-informed and to find out the information, and to some degree it behooves us to make sure, and I know that your organization is doing that, it behooves us to get that information out to people and to some degree to challenge some of the ideas that people have, that, and as you've been talking about palliative approach or supportive services, any way that we can make sure that people understand what it is that we're talking about, what services are available, and that this isn't kind of a fast trip to the end of life. And that's true for hospice as well as for palliative care, that these services are designed to deal with symptom management and to help people deal with both the symptoms of the disease and of sometimes the treatments as well. Can we go to the next slide?
Yep, you bet.
And so, again, this is speaking to a caregiver and what you need to know and around the goals of care. What I think about when I see that is that it's an ongoing discussion, both with the person that you're caring for and then with the healthcare providers. And what we often hear about is, a discussion about where things are or what do you want. But what you want changes over time. You might think, I want everything to be done for me. And then if the disease is progressing and you're getting worse and maybe the treatment isn't helping anymore, then your goals of care are going to change. And so developing an ability to have those discussions in an ongoing way with the person that you're caring for, with other family members if there are other people involved, and with your healthcare providers, so you're on the same page, and so that you are able to talk to the person, the care recipient, about what they really want, and eventually, if it's a terminal illness, about what they want at the end of life. and what kind of support and help they feel that they need and what they envision for the end of their life. And I think, again, one of our goals, your goals as an organization, and for us as caregivers, is to find all the ways to get the information that we need so that you can have these discussions. I mean, what I find fascinating now is that compared to when I was first involved in 1997, when I first got involved in caregiving, there's so much information out there that it's kind of tricky to figure out how to navigate all that information and to find it. And I think it's great to have an organization like yours that can help people navigate that so that you don't get overwhelmed by, well, where am I supposed to turn now? And how can I get the help that I really need? And how can I convey that to the person that I'm caring for? I think in terms of talking to the person that you're caring for, talking to their physician, one can hope that you've started that conversation relatively early on, that you have that kind of rapport with them, and you know, if that physician isn't willing to talk about those kinds of things, then you need to find another. Perhaps it's a palliative physician through a hospital or through a clinic who can help you talk about in a way that makes things make sense to you. In terms of the illness trajectory, it's often very hard to understand, where are we in all of this? What's happening? What's going on? And so being able to have those discussions with physicians, and I would say as well, if you've got nurses involved, being able to talk to them as well. Maybe you've got some hospice involvement at some point, and they're able to help you. And symptom management is, in a lot of ways, one of the key things, whether that's nausea or constipation. I can remember when I was caring for my sister that she said, you know, sometimes I think it's not the cancer that's killing me, it's the constipation, because it was, you know, from the opioids, and we all know this who've been involved in this, in cancer treatment, or that the opioids, whatever they are, whichever ones you're using, constipate people, and it's incredibly uncomfortable, and it's not just a minor thing. And so being able to get the support that you need and being able to talk about that and be taken seriously around those issues. So I think that's also really important. I know that, I don't know about it in BC, but I know there are a number of initiatives around training the caregiver, and there's a group in Ontario called the Change Foundation that has just funded a number of initiatives around helping caregivers to be more knowledgeable around accessing services and also giving the care that they have to do around medical equipment and how to use it. There's also a whole number of things like compassionate leave, which is both through work and is a federal program and can provide you with financial assistance. All of these things, advanced care planning, are things that you face, and you know, as a caregiver, they're often really overwhelming, and certainly for somebody who's got a terminal diagnosis, they can be very overwhelming. And who you can turn to and who you can talk to about these issues. I know as a hospice volunteer, I've been able to help some people around compassionate leave, and I know that I'm often talking to people about advanced care planning and understanding that these are discussions that we should all be starting long before we're sick, long before we have any kind of illness, life-limiting illness. We should all be talking about advanced care planning and about what kind of treatment we think we want and how we want to live our lives. In terms of caregiver coping strategies, I talk a lot about that in my book, I Don't Have Time for This, because as caregivers, you know, when I call the book I Don't Have Time for This, because when I was a caregiver, doing many other things, including a job and raising kids, I felt all the time like I didn't have time for anything. And certainly I felt like I didn't have time to care for myself. I mean, it was just impossible. I crossed myself off that list of people who needed help. But I think that we need advice for caregivers, and we need to talk to them in a way that isn't kind of condescending or insulting, like, the usual checklist that you see where, are you getting enough sleep? Are you eating well? You're not using drugs or alcohol? All of those kinds of questions. Are you going to yoga and massage? Well, most people don't feel like they have time for those things, those coping strategies. And so I think we need to find ways to talk to people about how they can ask for help and how they can get some help so that maybe they can take a break. Maybe they can get some respite, some much-needed respite. And there are, in various locations, and again, it depends on where you are, there are things like respite services or a hospice volunteer who can come to the house and spell you off so you can go out and not just get your groceries, but maybe even get a massage or get your hair cut or whatever something that takes you away just from full-time caregiving. So I think that we need to be talking to caregivers in a way that really does understand the kinds of pressures that they're under, and then helps them to find some support. Maybe it's a caregiver support group. And some organizations, the hospice that I volunteer at has a caregiver support group, for example, and they will usually send a hospice volunteer in to care for the person who has the life-limiting illness while the caregiver is out at the support group. So these are the kinds of things that we need to be looking at in terms of supporting caregivers, because we know the kinds of sacrifices that people are making, which they want to make. It's not that they don't want to do it, but they need to not destroy their own health or become exhausted as a result of caregiving. And so that's a part of this whole equation. Okay.
All right.
Are we at the end of the...
We are,
oh,
and so this is the, there's just this summary slide, which we're not going to go into here, but it is, as I mentioned before, included in the PowerPoint, which is available as a download on your computer. Will also be available with the recording on our website in about a week. So it just tells you, where to go for help for different things. That's the navigation piece that we've been talking about. We also have a list of resources, and I think before I post this online, I will add the Change Foundation. That was a really good suggestion, Katherine. They have some amazing resources. And
they really do. They're doing some great work around caregivers.
Right. So now we're going to open it up for questions, and we have some logged here that we've been tracking. So I don't know, Wendy, do you want to?
Sure, I can start. First of all, there's also been some really great comments being typed in, and the ones that I've. So I think we'll just go up to the top here for a second.
Yeah.
So I know, for example, someone just remarked that, I know it's difficult, we're kind of giving this 6 months to live is, highly subjective in terms of decision making. So it does put a little extra pressure also on, the individual with the terminal illness and the caregiver to be, as the guest mentioned, on top of their game. And so I think this presentation is a really good place to start in terms of knowing what and who to ask. So thank you to the panels for that. But one of the questions that I thought was really helpful, and this is very common just down island in Nanaimo, where if you don't have a family physician, you're a little out of luck. And so one of the questions was that if you don't have a family physician and you are looking to investigate the palliative approach, will a walk-in clinic manage this?
And maybe I should, as a family physician, maybe I should talk about that. Does that sound reasonable?
Yeah, sure.
Yeah, sure.
Very reasonable.
because it's not an easy answer. And so why do I get all the difficult questions? I would approach this on several fronts. Firstly, it may be that there are family physicians in your community who are accepting patients, and the only definitive way of knowing that is to go on to the College of Physicians and Surgeons of BC website, and they actually have a list of every community of physicians who are taking patients. So that's a possibility that there might be family doctors who are taking patients. There are currently in our community family doctors who are taking patients, and so it's possible that you could get signed on to a family doctor. Secondly, some communities, including again Powell River, now have nurse practitioners working alongside family doctors, and a lot of nurse practitioners are taking specifically vulnerable patients, and any patient who would benefit from a palliative approach is considered a vulnerable patient. Now, each community is going to have different protocols as to how a patient can be seen by an NP, and that would have to be something more that you'd have to talk about with your local health authority, which is going to be more difficult. But the health authority do have sites on which patients and caregivers can communicate about local resources. So there may be an NP who's doing this, and they can fill in these forms, and nurse practitioners can. Thirdly, to answer the question directly, the walk-in clinic should be able to fill out these forms, and what's more, the doctor will get paid. There is a special form filling fee for doing that, and that might be a pointed piece of information that you could give to a doctor in a walk-in clinic to help facilitate the form filling. Walk-in clinics do not have the continuity of care that family doctors have, but they should be able to fill that form in for you.
Great, thank you, David.
I thought in that same question, Wendy, they asked about what if you're all alone? So well, there's
that piece. Yeah. So I was thinking maybe that was a bit more of a doom and gloom question. I mean, it is real. There are obviously people who live alone and they're, with the terminal illness. What's the best way for them to access it? And I mean, I think it's that's where the greater community hopefully steps in, whether it's a neighbor, family friend, if they're part of community organizations. We've seen that here, especially with individuals who have family long distance, is that they often rely on their informal support networks to help step in and provide some support, advocacy, and through the process.
And I'll just make a quick comment here that we did run a webinar. Guest 3, if you go to our website, we ran a webinar specifically around building a gold medal support network. And even though it's coming at it from the caregiver perspective, if you are alone, I think there are lots of really good tips in that webinar about how to think about what you might need and who you might be able to ask for help. So I would suggest, that might be one way of looking at it as well.
That was
There's another route that I'm thinking about now, which is somebody who has received a palliative diagnosis while they are in hospital care. And different hospitals have different processes for getting patients linked into community resources. But certainly before your loved one is discharged, there should have been conversations regarding linking into community resources. And most hospitals will have a social worker who can make sure those forms are filled in. And so you can take advantage of that discharge discussion that really has to take place before somebody can be discharged. And that might mean a bit of making a nuisance of yourself, but that's what needs to happen. And it's usually by hanging around on the ward at around about 8:30 in the morning. That's giving you a little tip, but that's the way you do it. And that's when decisions are made in hospitals. And there is recognized process for discharging patients who would benefit from a palliative approach. And a careful, assertive, friendly caregiver can influence that process.
Those are good tips, David. Thank you.
Thank you.
There was one other question that I want to pose to David, because I know you are really you're good in answering these questions. I can attempt it, but you do it way better than I do. And it was around frail elderly people. And the question was, is frail elderliness a life-threatening situation? Because it's not like many frail elderly people, if you would ask the question, will they die within 6 months, you probably won't be surprised if they would. But it's not considered as a terminal illness, or is it? That's the question. Can you answer that question?
Of course, when we talk to palliative care docs and professionals, a lot of people talk about trajectories of illness, and there's different routes that people's journeys will take. And I have to tell you that frail elderly is a growing business. This is the route that a lot of us are going to take. And in recognition of this, the new criteria for getting people onto the palliative care benefits has taken that into account. It's called the SPICT form, and I can never remember what SPICT stands for. But there are certain criteria in there which are included in the frail elderly, which, if the doctor's filling it in properly, a frail elderly who has a limited life expectancy will indeed qualify for palliative care. Of course, this is a continuum, and sometimes by the end of the day I feel like a frail elderly, but I wouldn't qualify for palliative care. But it doesn't take much imagination to see that some frail elderly patients do qualify for a palliative approach. And Christien hit on one of the tools that doctors use, which is, would I be surprised if this patient died within 6 months? And family doctors, and also very interestingly, their medical office assistants, get very good at this. And it's as much a gut feeling as anything else. And often caregivers wouldn't be surprised either, although sometimes when you're very close to someone, it's hard to be objective about what their trajectory really is.
It's Pat. I'd just like to make a comment about the surprise question, which David just mentioned about, and I think is becoming very widely used now. I think, would you be surprised if this person died within 6 months? The answer needs to be no, I wouldn't be surprised, right?
Yes,
rather than yes.
I
just wanted to grab that because it's the reverse of what it's looking like there.
Yeah.
It's a double negative, which is confusing, but so it's kind of indicating that the healthcare provider, doesn't know for sure, but they certainly wouldn't be surprised if the person died in that period of time. Yeah.
That's good clarification, Pat. Thank you.
Okay.
So
I think if...
Go ahead.
I was just going to say, I think if there wasn't any other specific questions, we have some posted questions. What I will comment on very quickly before we go on to that next slide is that Katherine recently wrote a blog about her experience with palliative approach and care being provided to her service great aunt or aunt, in complex care. And if you have a chance, I think we should certainly include the link. It's a beautifully written blog post, and I think what it does is debunk some of the myths around when someone's in complex care that when it's their time to die, that they're often left alone, and that's not the case. And we see an incredible amount of care and passion around that individual's care as they approach death. And so I just wanted to mention that because I think, Katherine, it was a beautifully written blog, and I think it's really important that that we do see some of the wonderful components of care that do happen in complex care. And I myself have been quite privy to witness a number of clients whom I've provided support with during their last few days, and have really witnessed the care and compassion from staff as well in complex care. So thank you for doing that and bringing that to our attention.
You're welcome.
So if we go to the slide where there are some questions, I think that's a good place to start. I don't see any other questions.
Yeah, there was just one other question, Wendy, that came on the website, and that was actually from a clinician. It might be of interest. So it's, I'll read it out. I work with people who have chronic kidney disease. Some choose never to start a replacement therapy. In my role, I work with the person over the time to see what services they want and to be available to family and friends in this regard. How soon should or are the people choosing no life support treatment given information about palliative services, and what might be needed along the process in terms of equipment or services if they elect to die at home? How soon and in what way are those who will be supporting them given information so they can have time to ask questions and consider if they are ready to support this choice? I thought that was a really good question. Any of you, David, Pat, or Christine?
Well, I don't know the direct answer to that, but I do know that the Provincial Renal Program has been working on, I guess, pathways for what they called conservative treatment. I think that's the term they're using, David. Maybe you know more about this than I do. I just happen to, because I'm not working in the field right now, I'm sort of on the periphery. I'm a little nervous about that, but I happen to be in contact with some people with the renal program. So I know that they're thinking about this in terms of this trajectory and how to support people. And I guess one of the worries that I have as I listen to us, I think our emphasis with palliative care needs to be in terms of the person's needs and making sure that those needs are being met, whether the provider that meets those needs has a label of palliative care service or not. Because this has been one of the challenges with trying to deliver palliative care in such a huge country in terms of geography and whatnot. And, the important role of people like family physicians and home care services and whatnot who may not be formally called palliative care services, and yet in many communities are just expert providers. And, can do the symptom management and do the support of the caregiver and the client. So I think that with the renal situation, it's kind of like, well, is the person's needs being met by the renal team that's caring for them? Is there a role in terms of anyone else coming in that might have a label of palliative care? But certainly I think, as the person progresses in their illness, that if they could use equipment, then it is important that the patient and family are made aware of the palliative care benefits program. The benefits program doesn't cover all medication, and in fact the renal program may already cover some of the medication that the person is receiving. So I think it is a question of, let's look at the person's needs in terms of symptom management, in terms of having those goals of care discussions that are necessary for them to make the choices that are right for them, and the supports that they need to either remain at home or else know what their alternatives would be. I don't know if anyone wants to add to that, but it is hard, when we, as I say, if we think that palliative care can only be provided by specialists.
I'll take a stab at this as well, because I think renal disease is one of the good examples. So one extreme, the supportive and palliative care indicators tool, the SPICS tool, does actually lay down criteria for when somebody who has renal disease can be considered palliative. And they're pretty black and white criteria. But in a way that misses the point that people in a lot of organ failure trajectories should be looking at goals of care discussions long before they actually qualify for palliative care benefits, and should be having those discussions on a regular basis with their palliative care and with their renal teams. And it illustrates the point that disease-modifying treatments, like, for instance, dialysis and possibly transplantation, can still take place in the milieu of discussions around goals of care and possibly palliative care discussions. So these are not mutually exclusive concepts. And I think somebody who has the ability to think on more than one level and have palliative goals of care discussions at the same time as considering disease-modifying processes can have a much more enriched life. And that's really what we're all talking about here.
Mm-hmm. Yeah, I would echo that, David.
And I think you kind of made that comment, Katherine, before when you were saying that goals may change as time goes by.
Yeah, I think inevitably they do.
Mm-hmm.
Something that I want to add is we spoke with many physicians, and some physicians are really afraid to take away hope from patients. And that's why they're sometimes afraid to bring up discussions about goals of care and about palliative care. So that's why we took the route of really educate people in general and educate the community so that they can bring it up as well. And it's almost educating the physician sometimes and saying, that there are many ways of giving hope and providing hope. Mm-hmm. And research also shows that hope to actually die peacefully, or hope to just spend some time, still spend some time with your children, or see maybe a sister or a brother you haven't seen for a while. That is also hope. That also things that people grab onto when they are, closer to the end of life. And a really big one that came up is, for many people, is the hope not to die in pain or not to die in agony. And that is actually a good conversation starter. So, maybe you have a physician that doesn't bring it up themselves. So we really strongly encourage as well patients to know their rights and to know what's available, and then just bring up that conversation, and then your family physician will be happy to talk to you about it.
Well, may not be entirely happy, but will.
Yeah.
There might be a little discomfort. So I'm just looking at the time, Janet, which I'm sure you are as well.
Yeah,
what a fantastic panel of presenters and just some phenomenal questions from our participants. It's been a wonderful evening. So I know, Janet, you're going to want to close with a little closing and with our evaluation. But I personally wanted to thank everyone for taking the time to attend and provide their expertise and knowledge and personal experience.
Yeah, absolutely. So as Wendy said, I will be sending out an evaluation to everybody online, and would really appreciate if you could take a couple of minutes just to complete that. It really does influence what we do. We listen to any feedback that you are willing to provide us, and we've tried different things as a result of that, like having noon hour webinars and trying different formats and different content. So it's very, very important for us. We really appreciate it. What I will do is, so we always do this, we ask you to sort of, it's a call to action. What would you do differently as a result of attending this webinar? We're not going to follow up on this with you, but we're hoping that this will help you make some moves towards doing something for yourself. And just quickly, I'm going to bring a poll over to you, and we thought it would be fun to just see what kind of answers we get to this right now. So take a minute and answer this poll. That's weird. Okay, why is it?
That's because everyone's putting false.
Yeah, I think.
Okay, there we go. Yay!
Yeah.
Everyone got it right.
Everybody was listening.
All right. Good work.
Yeah.
Yeah.
Okay, well, and I would just personally like to thank all of our guests and presenters. Pat is a second-time presenter with us. Pat, thank you so much. Katherine, you are a hero, and you get to go to bed now. Thank you. And I'm going to make another plug for your book. I have gotten so much out of it, and would really encourage everyone to get a copy. It's not just about the clinical side of being a caregiver during a palliative journey. It touches on the human side, which I think is just so important. To David and Christien, thank you so much from the Sunshine Coast, and of course Wendy. So unless maybe someone has a last-minute question, or
well, there actually is one last-minute question here that I'm just reading.
Right.
It just says they're wondering if complex care sites have palliative care, physical setup, single-person room space for family to visit, quiet, and I mean I can't speak for every complex care facility, but for example, I know here in the Comox Valley that we do, and typically the way it works is that we actually have designated beds, but when those beds fill up and someone's in complex care, and they often have one room, I know just within our region, where it is a single room, and they do their very best to transfer that individual into that space. And I had a really unique, really powerful experience working with a client and her family. Her only daughter lived in the States, and her mom was dying, and I was in every day, and I was really impressed by the care staff, just their caring and compassion. But one thing that that we did with her mom, I mean, her mom was very demented, and as we know, hearing is often the last thing to go. And every time I went in, I would, bring in my cell phone, and her daughter would call me, and we put up the phone to her mom's ear, and she'd often, play a song on a guitar or speak to her mom. And I'm just bringing that up because the facility was so accommodating for her mother's needs, and the ability to have anyone come in and provide support and care and comfort to her. So I think that's the long-winded way of saying yes. I think it's just around working with the staff who are currently in the complex care and finding out how they can best support that individual.
Yeah, I would just like to echo Wendy that there are a number of initiatives within residential care. I know in BC and I know Ontario had a big initiative in this area as well, so I suspect all across the country in terms of looking at providing a palliative approach in residential care facilities.
Yeah. Yeah, lovely comment. Okay, so it is 8 o'clock, and I'm going to end the meeting now. But again, thanks everyone for signing on. If you'd like to see it again, we'll have the recording up in roughly a week. And happy Family Caregiver Day week. day, week.
Yeah.
All right. Thanks so much,
Thank you,
everybody.
everyone. It's midnight in New Brunswick, so good night.
Yeah. Good night in New Brunswick. Thanks
Yeah.
very much, everybody.
Good night.
Good night.
I'm going to go watch the sunset soon. Have a great night, everyone.
Bye-bye.
Good night.
Bye.
Bye.
Bye.